Okay, I think we'll make a start there. Hi everyone, welcome to this HCV Action webinar looking at hepatitis C in the justice system and particularly looking at how we can go beyond the work already done in prisons. My name is Noah and I help coordinate the work that HCV Action does. We have sort of two parts to this webinar. The first part will be your sort of traditional lineup of presentations and talks, along with two Q&A sessions. Then after that, we will have a more sort of interactive discussion in breakout groups. With our facilitators. So I'll just run through our speakers that we've got today. First, we've got Georgia from NHS England talking about the work that they have planned in preparation for the next year. Then we have Carrie and Colin from the Hepatitis C Trust, who will be talking through some of the work they've done on the Through the Gate peer project that the Trust has. And then finally, we have Mary Kelly, who is the interim head of the South East Lancashire cluster for the National Probation Service, who'll be sort of giving probation's perspective on hepatitis C and how you can best work with them. Tiny bit of housekeeping before we start. Please do type any questions you have in the Q&A function. We'll then come to those and answer them in the two Q&A sessions. And then finally, just please do keep yourself muted and your camera off during the talks. And now I'm just going to hand off to Georgia, who is going to talk about the work NHS England is doing.
Thank you. Hi everybody, my name's Georgia Threadgold. I'm the Improvement and Delivery Manager at NHS England and Improvement's national team for the Hepatitis C Elimination programme. I'd like to say a big thank you to HCV Action for arranging all this, and thank you very much for inviting me. I'll be giving a NHSE national perspective on the planned programme for probation testing and treatment for hepatitis C. So next slide, please. Thank you. I've put this first as I'm quite new to the team, so I started in the summer. I came from a health and justice background, but concentrated mainly on adults in custody. So it's really nice to work on the what next when somebody leaves prison, other parts of health and justice and the rest of the Hep C programme and pathway. And I just want to say, please do get in touch. We're always here to help and support. If you're delivering one of these programmes, it'd be great to hear from you. And if you need any support, then please let us know. Or if you're just interested and want to know a little bit more, please do get in touch. We do want to hear from you. And obviously we want to give you as much information about the programme as possible if I don't answer any of your questions well enough. So we're always here to help. So next slide, please. So what I really wanted to do at the beginning of this is to highlight the programme in context. So there's a number of current challenges that have meant that we have altered the programme due to things going on. So obviously the main one's COVID. I'm sure everyone's heard of that one, and that's affected the programme in a big way. So the probation service is still running, it's still open, but they're skeleton services and a lot of them have stopped quite a bit of the face-to-face contact with service users. So obviously that's impacted on the hepatitis test and treat. Our approved premises, for instance, are still operating, but perhaps in just a different way. And they are operating through the exceptional delivery models that have been implemented by HMPPS. Another side to this is the changes to the probation service, which will happen in April 21. So that's a structural change. And we've got to be mindful when we're planning and delivering these sorts of services that probation staff are going through big changes, and that will impact on the way that they can deliver services with us as well. And so that's affected how we've planned the programme, which I'll speak more about soon. So next slide, please. So following the success of the prison high intensity test and treats, or HIT sessions that we've done, they're testing, for anybody who doesn't know, in prisons on a fixed period of time, so a few days or a couple of weeks, where everybody is offered a test. HMPPS have been really on board with both the prison side and also encouraged us to do something in the probation settings as well. So there are three elements. Approved premises are the start, and that's primarily what I'm going to talk about today. Post-sentence supervision, which will hopefully be starting early in the new year. and community sentence treatment requirements after that. They're sort of a part that we've not planned so much at the minute because of the reconfiguration that we've talked about in the probation service. They'll come afterwards. Although I'm talking about approved premises today, there are some ODNs that have done more than approved premises that have been in other parts of the probation service, but that's been decided locally in partnership with HMPPS. But the national programme at the minute is concentrating primarily on approved premises. Next slide, please. So for anybody who doesn't know, approved premises provide supervision for those who are at very high or high risk of harm, and they tend to be individuals that have been released on licence. Some people still call them bail hostels, but they do accommodate small numbers of people on bail or with community sentences, but it's often people who have been released from prison on licence. And they provide purposeful activity to reduce reoffending and to encourage reintegration into society. So from our perspective, there's 101 of them in England, and a small number of women-only approved premises. They're not distributed evenly throughout the operational delivery networks. So, for instance, there's one ODN that has 13 approved premises and a lot that only have a handful, so they'll only have one or two. And those ODNs will have engaged with approved premises differently. So some, when we did a scoping exercise in January, some were working very closely with approved premises and had been for a while, and some had never had anything to do with approved premises. And a lot of that is partially because there's been so much attention given to the prison settings, high intensity test and treat. So the ask from our perspective was to ask ODNs to engage with their approved premises on their patch. And the programme has been that they need to engage with them, but we're not expecting that, for instance, the ODN that has 13 approved premises has to conduct high intensity test and treats within them before March. It's just one for now. So next slide, please. So what does the work plan for the ODNs actually look like? So what the NHS England and Improvement National Team for Hep C Elimination are looking for is anything that each ODN would like. So it will look different in individual ODNs. So for instance, they can choose to train the staff in the approved premises themselves to conduct testing themselves. That's absolutely fine. Or what they can do, and I think what most ODNs have been doing so far, is to conduct their own sorts of high intensity test and treat sessions within the approved premises. So that might be, they might go in every week, they might go in once a month, they might go in once a quarter. That's completely up to them. And actually, from our perspective, it'll be really interesting to see what each individual ODN decides to do and how that works in each area. So funding has been given to each ODN to use by March 21, and again they can do what they like with that in the approved premises. Anything else, as well, as we've said before, if they are in other settings within probation, that's absolutely fine. They can use the money for that. But at the minute, we want the approved premises to be looked at first. So to do this, we've been working very closely with HMPPS and the Hepatitis C Trust. Will also be involving revolving doors within that from next week as well. And the use of peers as well, as always, is really central to this programme. And depending on what each ODN does within the probation settings is how the peers might be used. So they might be involved in the training of approved premises staff to conduct their own test and treat in the future, or they might be at the high intensity test and treat sessions in the approved premises. Whichever way, they'll be a very central part to the programme. Data collection is important as ever. Hopefully will be inputted on the hepatitis C testing registry. And at the end, we're looking for similar to what we asked for with the prisons, which is having a bit of an evaluation report at the end. And we've already actually received one from one of the ODNs. So I'll give you a bit of an update on how one ODN has already done this. So this particular ODN contacted HMPPS directly and was given permission for a high intensity test and treat session in September of this year. So it's been during COVID. So again, it was very different than how we might have done it a year ago, but it was still possible. And they had very good uptake from this. And how this ODN did it was to replicate the outreach clinics process, utilising the Hep C Trust peers, which worked really well. They used oral swabs for the tests, lab bloods for the viral loads and genotyping, and a Cefiad was not used due to the small size of the approved premises, which is what we've heard from other ODNs as well, that they're not, that isn't the central part of how they're doing it, but others might choose to use one. They managed to test all residents and actually some of the staff as well, and they've decided that they're going to repeat this process every 3 months. Now that's one ODN's way of doing it. Other ones might want to go in every week if they have capacity to do that. Others might say, okay, we'll go in once, but we want to train staff to be able to do it from the approved premises perspective instead. It's completely up to ODNs. Next slide, please. And this is what we're hoping to do in the future. So back to the sort of bubble slide. So the approved premises is the first part. The next part will be post-sentence supervision. Again, some ODNs will have already been into those settings. That'll happen in January, February next year. And then it'll be on to community sentence treatment requirements post-April 21. So that's what we're kind of looking at then. There might be other parts as well that ODNs are interested in looking at. So one ODN got in touch that they're interested in doing some testing in courts, for instance. That's sort of a future plan, and we're completely open to doing something like that. So yeah, we're open to lots of different settings. Next slide, please. And just to wrap up before I go over time, just to reiterate, we're always here for support. If anybody needs any extra guidance or wants to ask any questions, or you're just interested in the programme, please do get in touch. That's our team's email. I'm sure most of you will have seen it already, but in case you haven't, we're always there, and we look forward to hearing from you. So that is a whistle-stop tour of probation settings, Hep C test and treat.
Thanks very much for that, Georgia. That's a really useful overview. So we've got time now for just a few minutes for any questions to Georgia before she needs to pop off. So if anyone has any questions that you would like to present, then please do just pop them in the chat and I will put them to Georgia. But I'll ask one just to sort of kick us off. So obviously it seems like we've got to a point where there's quite good buy-in from sort of the top of HMPPS for doing more on hepatitis C in probation services. I wondered what your perspective is on sort of to what extent that has filtered down to like individual probation workers, and whether there's anything more that ODN staff or kind of anyone who's in this meeting should be doing to sort of make sure that it becomes a priority.
Yeah, that's a really good question. We've actually had a few queries this week on something very similar, and that's what our working group with HMPPS and ourselves is for, and the Hep C Trust are also involved in that. So we had a query from a few ODNs that some they felt like there could have been more support from ourselves and HMPPS, and there was a bit of a miscommunication, I think, on something. What we were able to do with that was to take it forward to HMPPS, and they were able to disseminate some comms and engagement on that query. So I think the ask from ODNs is just to keep us updated. So if there are any problems, just let us know. And if there's something that nationally there needs to be a bit more steer on or some clarity, that's our job to sort that out. And we can do that with our pretty good partnership with HMPPS.
That's great, thank you. So we've got a question here from Dusan Jovovic. Thanks, Dusan. So Dusan wants to know whether you have any numbers of how many people were tested and treated during the lockdown period.
Good question. Not off the top of my head, no. That also depends whether they mean just probation or generally. There has been a bit of a dip in the numbers of people tested and treated during the lockdown period for obvious reasons, similar to other services as well. There's been a definite dip. Oh, he's just said probation. Yeah, I can see that. Probation, No, I don't. I don't think, from my knowledge, there's been any reports submitted on the number of people tested and treated in probation. In the one ODN that I mentioned earlier, the one that did the test and treat in September, they tested 15. So that's in just one approved premises. I'm not sure about other ones.
Okay, thank you. I thought something it might be good to get your perspective on. I think we're going to be discussing this later in the breakout rooms, but it might be good to get your thoughts on it before you have to go. So obviously probation services kind of cater to different groups. So there'll be people who have been released from prison, but also people who have been given a community sentence and so haven't been into prison. I wondered whether you had any thoughts on whether there's sort of whether you'd expect there to be different levels of engagement between the two, whether there needs to be a different approach. Is that something that's kind of been considered?
Yeah, that's a good question. So my personal perspective is that everyone should be treated the same, so it doesn't really matter which service we're engaging with, whether that be a prison or probation or drug and alcohol services or any of the other elimination initiatives. They should be treated the same. They'll have similar queries, I imagine, on the test and treatment, and that's why a national perspective is really useful. Just to bear in mind, I suppose, the prisons and the probation service are different. They are different individuals. So I suppose it's just engaging with them on an individual basis. And yeah, that's about it really.
Thank you. And well, just one final one from me, but if anyone else has any further questions, do put them in the chat box. In terms of just sort of ODNs engaging with the approved premises, I guess what would be your sort of main bits of advice, particularly if anyone was sort of having difficulty engaging? Would it just be a case of sort of coming to you as the central team again, or?
Yeah, so each area, each region has their own approved premises network manager. If each area knows who that is, then you can engage with them and they can flag any national issues to either ourselves or the HMPPS national team. If you don't, then that's what Hep C Enquiries is for, and we can find that out and just flag it nationally anyway. So if you know the approved premises area manager, that's great. If not, that's absolutely fine, and let us know and we can sort that out.
Terrific, thanks. Okay, so we've got a question here from Simon Morton. So Simon says, drug services and probation services have significant numbers of clients in common. So will there be some local coordination and communication factored into the project?
Yeah, hopefully. And so that's something that we're working with HMPPS at the minute. So they've got a focus group that's starting in a couple of weeks, and communication and local coordination is a big part of that. And they've got some third sector organisations involved as well, and lived experience, for instance. So that will be coming soon, hopefully, yeah.
That's great. Okay, well, thanks very much for your time, Georgia, and for giving us an update on that.
Thank you.
That's
And
really
I'll
helpful.
remember that you can get in touch with me by email anytime if you've got any further questions.
That's fantastic. Thank you.
Thank you.
Okay, so we are now going to hear two presentations back to back, and then we'll have time for some questions for both at the same time. So the first one is going to be on the Hepatitis C Trust's Prison to Community Peer Project. So I will now pass over to my colleagues from the Trust, Colin and Carrie, who are going to tell us about that.
Hi everybody, hope everybody's all right. I'm just waiting for the presentation to come up. My name's Colin Lawton. I am the regional manager for the prison team in the north. I don't know if Carrie wants to introduce herself.
Hi everybody, I'm Carrie and I am the regional manager for the community team in the north.
So this is a joint effort. I'm going to do the first half of the presentation and then Carrie's going to finish it off. I think first of all, just to mention, follow me process. It's nothing new. It is what it is. It's about being able to follow someone from prison back into the community, which we know gets done in many different ways and called different things, from through the gate to obviously probation, what they do as well for following a prisoner back into community. But this one's actually just focused mainly on ODN nurses and our prison peer educator and our our community worker working together to be able to find and not lose that revolving door prisoner who goes into prison and only spends a short amount of time because he or she is on remand and they've tested positive and they start treatment, and we lose them at the gate once they revert back into community. That's the idea of the pilot, and we put it together in the northeast, and this is where we started it. Next slide, please. So just to give you some background, 12 months ago, this is where conversations all came about discussing how do we stop losing people when they come out of prison who are positive. My position over the last couple of years was to take a team into the prisons, which we successfully done. So now we have the team in place. It made sense that we could sit down and actually start looking at this pilot. So the first one, the community follow me, it's nothing new. It's been in our community in many regions and pretty much most of the UK now for the last few years. And it's extremely successful to the point where we follow a patient all the way through treatment, from first, connecting with that person, getting them tested, starting treatment, making sure they get to the hospital, and then actually finishing off with the blood test to make sure that they've cleared the virus. So this is kind of like why we wanted to follow someone out of prison into the community team. So there is obviously established referral pathways in many prisons, all in different shapes and sizes. So again, like I was mentioned, there was nothing new. It's just a case of like working out how we were going to put ours into place. Issue of patients released from HMPPS without adequate linkage to treatment, particularly when release date is not fixed. So this is where we were looking at. We don't want to be obviously trying to follow everyone in the prison, because not everybody gets out still needing treatment. This was basically for people who don't have any sort of date at court and they're just randomly getting out and we're losing them. The Hep C team, prison team, was now established in all the prisons, especially in the northeast, so we were ready to do this. And our prison worker and our community teams were working very closely together, including me and Carrie as managers, so it just seemed the right thing to do at that time to start this up. Next slide, please. So the pilot itself, there was a lot of thought went into the pilot, because you're trying to introduce another referral system into a prison system that already has 101 other referral processes that everybody else is trying to do. So to make this process a little bit different and more focused on HIV, we partnered up with our good friends, the ODN from the Freeman Hospital and the smoke sites. And it was quickly formed that through regular meetings and actually sitting with the nurses, that actually the BBV nurse was in the right place at the right time to be able to offer someone a follow me. So for instance, when somebody's ready to start treatment and that BBV nurse is there just ready to get consent to actually say, okay, we're going to start your treatment, having our peer educator from the prison who's been through treatment themselves, who's been in prison before, if they're sitting next to the nurse, they're in the prime position to speak to the patient and say, look, let me follow you back into the community. If you get out, I'm here. This is Tony Jefferson. So Tony introduces himself. Ideally, that is the best way we found this, but obviously because of restricted in the pandemic, that has hasn't worked as well. But we're hoping to reinstate that. But this was the thought pattern anyway. It's going to be a joint nurse, prison peer educator being able to sign someone up to a follow me there and then. So you've got the clinician and the PPA refers directly to the Hep C team. So when that referral comes through, it doesn't go anywhere else. It comes straight to the Hep C team itself, and it goes straight to the community team, who can then register that person straight away, and we're pretty much in a position ready to go and find this person. So the key focuses was all about people who were sentenced for less than 6 months. So we're looking for that person who's just starts treatment and we lose them. And after some conversations with the ODN and then the prison, numbers are really high when it comes to remand and people coming in and getting out straight away. So it made sense that we focus on remand prisoners and also people who were on HTC and bail, and again, who just aren't in long enough for treatment. Next slide, please. So I'm not going to go through the nitty-gritty of a whole pathway, but this is just a picture of how it works. There's 3 levels to the pathway, which are relevant from the point when someone is actually tested to actually seeing the nurse and starting treatment and meeting our peer. The best way of describing it, if there's a planned release, it's fantastic, because if someone's in prison for long 6 months, we've met them, they've signed up to the Follow Me, or, you know, we're going to stay with them throughout their stay in prison. We're going to get them on our peer-to-peer programs. They're going to meet our peers. Hopefully we'll train them as a peer. I can actually say this pathway has worked well in Home House, where we've trained someone as a peer, we've met them at the start of treatment, they've completed treatment, and now they're actually a volunteer peer in the community working in Teesside. So that's kind of like the bottom pathway. The top pathway is when someone's transferred, because we're in the North East prisons. If someone again signs up to Follow Me and they do then get sentenced and again transferred to Home House or Northumberland, we follow them up to Northumberland or Home House because that's where we work. So again, we'll make sure that we go and find them and make sure that they finish the treatment. And again, we'll offer them to be training into peers and do our courses. But then the middle one, the unplanned release one, is when everything has to work smoothly. So, you know, when somebody goes to court and they're getting out and we know that they've got out, and the information has already been sent to our community team, this is when we would double up. The peer, the prison peer educator and the community worker would then go off and try and find this person in the community. That's how it all works. Next slide, please. So I think this is probably the best slide to show everybody, to show how it all works. So first of all, on the right-hand side, we've got this wonderful picture of Sue Riley, who's our community worker, and Tony Jefferson, who is the prison worker. And without the combination of good working together with these two, that this Follow Me pilot wouldn't have worked as well as it did, because I do have to say these two are fantastic workers who go above and beyond to try and find somebody in the community. So just a little example of how this all works. This is a bit of a patient journey that we managed to pull off, just to give you an idea of the difficulties that there is to try and find somebody. But actually, if you leave a few crumbs wherever you go looking for that person, that you will actually find the person eventually. So just to show you that a patient was referred from Home House in January. On the 8th of Jan, the patient was seen in the prison. The clinical team from the North East ODM referred to the Hep C team, just like the pathway tells you to. On the 23rd of Jan, the community and the prison staff travelled to Cumbria to do like an assertive outreach, as we knew the patient now had been released, but they hadn't finished treatment. So they went all the way to Cumbria. Patient wasn't found, but at the time when they were up there, they went around all the supported services that they knew of. And I think the most important part is because Sue and Tony are peers, they know the services, they know where to go and look, they know where to go and ask people if they've seen them, i.e. like a soup kitchen or where people go begging. You know, this is the idea of the Follow Me itself, is to follow somebody that's pretty much invisible at times. Patient details were held in case of further contact and additional outreach. So a bit of time went by, but then on the 14th of July, there was contact with the patient responding to testing event posted and working and able to ascertain patient's history via records. So immediate telephone support was offered and the appointment was arranged with the Hep C team. And then on the 22nd of July, met with the patient in Workland, offered support and completed DBST, as patient had not completed a full course of meds due to unplanned release. And just as it says on the bottom, results showed patient to be PCR, successful treatment despite not completing full course. So it kind of like shows that the Follow Me does work. It takes a lot of patience, but yeah, it's a process that we're very proud of, and hopefully you can see the goodness in it all. And I'll pass you over to Carrie.
Thanks, Colin. Can we just move to the next slide, please, Noah? Thank you. So the next part of our presentation is about going over what we found as a result of this and how those patients that we did engage with, kind of what that looked like, I suppose. So there's a bit of an overview here. I don't want to talk about COVID, but I guess we have to mention it. So COVID has impacted upon this to some extent. You can see there was a month without any referrals. We were probably in full lockdown mode at that point. But the take-home message is, so we had a total of 41 referrals that were received over the course of the year, and that was within the North East ODM. Of those 41, 17 we knew were out and required some sort of assertive outreach to try and make sure that we were able to support them and check that their treatment had continued. We did know of the 41 as well. 4 had already completed their treatment in custody and they were successful completions, and we didn't need our support of those people. The remainder are either still in prison or we are awaiting information. Now, if we can just move to the next slide, I will focus on the 5 that we did find, because there's some really interesting things in here. So of these 17, just like Colin described there, this was Sue and Tony trying really hard to do whatever they could with the information provided to go and find these people. So of the 5, we had one person who, which is actually the case study that Colin just spoke about. So we were able to complete the SVR with them. They had successfully completed treatment despite not taking the full course of meds. And we done that with dry blood spot, so that went straight off to the Freeman, and that was a brilliant result. The next person was found again by Sue and Tony, but at that point in time the person wasn't in a position to engage on that day, so it requires some further support, but it's progress because we can go back and try to catch up with that person. Next person we actually came across whilst in a clinic anyway, so that was good. They had obviously been linked up to care, but we were at least able to offer support because they were sitting in that clinic room waiting to be tested again in the community. That was in Middlesbrough. Next person we found had actually completed in prison, we just weren't aware of it. So again, really good result for that patient. And the last one is really interesting, and I think highlights why this is even more important, because the last patient wasn't just found, they were found, they had completed treatment, but that person had actually put themselves at risk since being in prison and requires a retest. So we are supporting that person around that at the moment. Then if we can just move on to the next slide. So over the course of the year, this was a pilot, and we discovered kind of various things, I suppose, that were particularly useful or had been challenges along the way. Like Colin said, the links between our own teams, the clinicians, the ODN, the fact that we have spoken to them so consistently has without a doubt helped, and the fact that we've all got a really good relationship. We're able, during this course, there were lots of points where it didn't perhaps work so well, or we realised we had to modify the form, so we were changing bits and pieces along the way. The next couple of bits, that pathway that Colin spoke about, that was originally written before the pandemic and quite obviously focused largely on peers and our staff being able to go into the prison. So it's a shame that at the minute that's a difficulty. So we're kind of in the process of trying to work around that, I guess. But certainly if a peer can be there, we know that that increases patient engagement, and it means that we're more likely to get the information that's going to enable us to find that person when they're released as well, make sure that support continues. And again, that's just to highlight that some of the information is a little bit sketchy at the minute around those people that are still in prison as well. So I think that's to be expected, that some of the information isn't quite up to date for some people. Next slide, please. So what I've shown here, this is the actual referral form for the Follow Me process. I believe it will be made available online, and it goes direct to an email address, which I think is on the next slide. But the reason I wanted to demonstrate this is normally what we would have had would be a peer in that clinic where that person is having their initial engagement with perhaps a BBB nurse or a Hep C nurse. And the form covers various bits of information, but for us, the most important part of this form is this bit that is circled, because this is the information that requires us to go out and be investigators and try and offer support to that person. And I think when it's worked really, really well, it's when we've been able to get that information. So it's looking at information that isn't just, what's your bail address, because that may well be not where that person is for a large part of their day. It's about kind of having that conversation with somebody and saying, okay, where are you really going to be? Is there a service you go to a lot? Is there a supported housing provider? And popping that information in the box, because that's where we're probably likely to find these people. Next slide, please, Noah. So finally, just to say, so we have been in a position to roll this out nationally now. The Hep C Trust, we're actually in 20 of the 22 ODNs right now. So where we are able to, the referral form is sent to our dedicated email address, which is listed there. We have somebody central to that will then fire that off to the appropriate peer support lead for the area. So for argument's sake, that might be Sue if it was in a northeast prison. She would receive that referral, have that information, know roughly that the person might be due out, and then would know how to go and engage them with her peers. What I would say, and my final point on that is, it is a pilot, and so now we're rolling it out. We're still very much in the position of wanting to take feedback from people, and I absolutely appreciate that each ODN kind of has slight differences in how things might work as well. So we based this largely on the northeast and then rolled it out, and we have adapted the form a couple of times just to make sure that it's definitely going to work in the right way. And I think one of the groups today is actually about that, just kind of making sure that we're doing what we can to make sure we're supporting our clinicians that are going in and trying to complete this information too. So please do, if you do have any feedback, get in touch with me or Colin or anybody else at the Hep C Trust, and I'm sure the message will get across. Thank you very much.
Fab. Thank you, Colin and Carrie. That was really great to hear about. And like you say, really interesting pilot. So now I will just introduce Mary Kelly from the National Probation Service / HMPPS in South East Lancashire. Mary, take it away with your talk.
Good afternoon, thank you. Yeah, just to introduce myself, Mary Kelly, Acting Head, South East Lancashire National Probation Service. I need to say this is my personal phone I'm on because Zoom isn't compatible with our work IT, so I don't have a presentation to share with you. I'm going to use the 10 minutes that I have to really set, I guess, the scene in terms of some probation context, and then talk about Hep C testing in Lancashire, some of the challenges and successes that we've had. So first of all, to talk a little bit about the probation service. In 2014, we had a joined up probation service. We worked in former trusts. At that time, I worked in Merseyside Probation Trust. But in 2014, we were split. So we were split into two separate organisations, the National Probation Service and then a number of community rehabilitation companies run by private sector organisations. So in the northwest of England, we had Sodexo covering one area and Interserve covering Greater Manchester, Cheshire and Merseyside. And the National Probation Service became part of the civil service. So I'm sure you can appreciate the complexities of trying to work as probation providers, yet very different organisations. The National Probation Service currently manage the more high-end, riskier service users. So we will deal with high risk, very high risk of harm, violence and sexual offenders. We manage all sex offenders. We're responsible for all court work. We're responsible for the approved premises that Georgia talked about earlier, and also multi-agency public protection and sex offender treatment. The CRC, so the community rehabilitation companies, they're responsible for all other service users, so low risk, medium risk, and they provide interventions apart from sex offender treatment. In terms, just maybe to point out, and it's probably important for Hep C awareness, is that most drug users are managed by the CRC, simply because a lot of their offending is acquisitive, so by our definition isn't high risk. So you're talking about burglaries, shop thefts, etc. We do have some substance users more likely to be robberies, etc., and more dangerous perpetrators. And of course, I do appreciate that it's not drug users in Hep C testing, but clearly they are a client group that we have a focus on. So the probation service is actually coming full circle, and Georgia alluded to this earlier. So in 2021, we're being reunified, which for us is great news. It is really difficult working across different organisations, but as it stands right now, we are two distinct different organisations. I'm going to talk about health within the National Probation Service. So we have a national lead for health and justice, and we have a health and justice delivery plan. It's a 3 or 4 year plan. And every region has a senior lead for health and justice. So I am the co-lead in the Northwest. And we then have a delivery plan that we take forward within our regions, and we have a SPOC in every cluster. So our clusters are like Liverpool, Sefton, Cheshire, Cumbria, etc., smaller geographical areas. I'm going to just touch on the delivery plan so you know where Hep C features in that. There are 7 priorities. The first is mental health and well-being. Second is improving provision for substance users. Third, physical health. Fourth, social care. Fifth, learning disability and autism. Sixth, personality disorder. And the 7th is suicide prevention. So Hep C fits nicely, I think, in 2 of those priorities, and that is treatment provision for substance users and also physical health. And it is a key feature in our Northwest plan. What I would say is that there are disparities across the Northwest. So in some clusters, there's been real progress with this, for example, Lancashire, whereas in other areas, there really hasn't been any activity happening or very minimal activity. So just to move on then to talk about the Lancashire initiatives. Last year, we ran 2 clinics, one in Blackpool and one in Burnley. So the clinic came to us and we did the testing on site as a one-off activity. Both of those were really successful, and I can't recall the numbers, but it was possibly 20, 30 people tested, so real success. Since then, and Colin and Carrie will be aware of this, we've got an ambition to have our own staff trained to test. So we have people who are on community sentences, so they are inducted straight from court. And then we have people who are released from prison who come to us that are inducted from prison. And the ambition was to actually have our staff trained so that every induction, Hep C, would be part of the induction process. The real obstacle with that was just to get health and safety approval. I am confident that will happen because we drug test in our offices, and our staff do swab drug tests. If we can do that, we can also do Hep C testing because it's very similar. But we didn't quite reach the sign off on that when COVID arrived, and COVID changed everything in terms of this ambition. First of all, we stopped seeing people in the office. So that was obviously during lockdown. But then drug testing ceased, and it hasn't been reinstated yet in the offices. It has been reinstated in approved premises. The challenges that we're facing around bringing drug testing back into play is around PPE, the sheer volume of testing that needs to be done, COVID risks, lab capacity, and also just the variations in terms of local lockdowns, because obviously we're now in tier 3, very high risk. So that's been stalled. I don't think that will happen this side of Christmas. I think we're looking at 2021. So alongside that, our Hep C plans have stalled. But we've been creative, and we've come up with some, other ways of doing things. And in November, we're going to run another clinic at Burnley. So we have the Hep C van booked in, and it's going to park in a car park, and we're going to get our probation staff to make sure that anyone who's newly sentenced or newly released is booked in that day, and to offer Hep C. So I guess in a nutshell, what I would say is it hasn't been, plain sailing, but there's a real willingness on our part, and certainly with the partnership work, and for us that is key to it. It's about getting together, seeing the benefits of this for our service users, and selling those benefits to probation staff so that they engage with the process. I think, one of the questions I think earlier for Carrie was about the differences in engagement and what to do if you struggle to engage with probation. And I think it needs to come from the top. So I would certainly escalate things because it should be driven from the top. And just to finish off, I will say, and I'll remind you, it is embedded in our key priorities and it is high on our agenda. So we are willing and we're really keen to take this forward. So I think that's my time. I'll pause there.
Hi, Mary. Thank you. That's a really useful update. Thank you for that. So yeah, we do now have a few minutes again for some questions for Mary and for Colin and Carrie. So if anyone has any questions, please do put those into the chat box and I will pass them on. But yeah, again, just to start off with one for you, Mary. What do you think is the attitude of people who you support in probation services towards Hep C? Would you say that stigma is still quite a big issue? And if so, I wonder what your perspective is on sort of how best to kind of challenge that.
Is this staff or our service users?
Yeah, the service users is more what I meant, yeah.
Okay. To be honest, I'm not sure. It's been a while since I've worked directly with service users, and historically, it was the drug users who would have tested positive. But I think there possibly could be an improvement in awareness and treatment provision, because outcomes now are so positive that I don't think we should have that stigma around anymore. But potentially what we do need to do is some more education and awareness, and we can do that via our probation staff.
That's great, thank you. Colin, question for you.
Sorry, I was just going to come back on that point. We have found that the clinics that we've ran, that people are really willing to be tested, so we haven't faced any challenges around stigma. That's not to say it wouldn't happen.
That's good to hear. So Colin, yeah, quick question for you. I wondered if you could just give a quick update on sort of how things are progressing in getting peers back into prisons, and whether some of that progress is also starting to now be reversed as we're seeing the measures get a bit stricter.
Yeah, it's been a to and fro, I would say, sometimes in, sometimes not, but each area is very different. Each prison's very different, even though there's like a standard command mode and stuff, but each governor seems to govern the jails very differently. So for instance, in the Northeast, we're in very regular in the Northeast. We're doing testing. We actually ran a group for the first time in Durham this week, with people coming along to a session, which is the first time we've done that for months, you know what I mean? But then you go to different areas. The Yorkshire prisons, they're running their prisons very differently, where you can go in one prison, but then you can't go in one for another 2 weeks. And then you move across to Merseyside, that are in level 3, and there's no getting in any prisons over that side at the minute. So, you know what I mean? It's a case of our peer educators are doing the best. But we are using technology, you know, we're using email prisoner, we're using our newsletters and our leaflets. So there's regular things going in, and we still have trained peers in the prison who we're in contact with as well, so who are giving out our information. So, you know, COVID's here, but we're finding ways around it, so it's going all right.
Good to hear. Okay, so a question for Mary from my colleague Stuart from the Hep C Trust. So Stuart asks, what are the chances of getting Hep C testing included as a desired outcome that could show that someone is engaging with their own healthcare, and then could that sort of serve as a positive towards their rehabilitation?
Oh, a very interesting question that. Each of our service users have a sentence plan that's directly linked, I suppose, to their offending and their risk that they posed. And one of the things that we have set as an objective on our health and justice plan is to do some training for our offender managers around incorporating health objectives into the sentence plan, because clearly if someone has poor health, the likelihood of them engaging with other interventions is reduced. So it is something that is on our radar, and you're just making me think about how we could actually engage with, you know, perhaps the Hep C Trust in delivering some training for staff around that. So there's definitely scope for it. It is on our radar and it is embedded in our delivery plan.
Okay, thank you. I mean, you've slightly addressed this next question actually just there in your response, but someone was asking what training are your probation staff given around Hep C?
We have had some training actually as a result of the testing, and it's been welcomed, but we have a really fluid workforce. We're recruiting and building all the time. So, you know, each year, even just in Lancashire, we have about 15 new probation staff, and I'm conscious that perhaps there's a gap there where actually our trainees should have it embedded into their learning and development. And again, happy to take that forward.
Thank you. Carrie, something that I was wondering about from your presentation, I wondered, does it present more challenges when someone is leaving a prison in one ODN area and then moving out into the community in another ODN area, or is the referral process sort of good enough that the trust will follow them regardless?
I think the process itself is good enough. In terms of the practicalities around that, there haven't really been many issues. Normally it's just about us communicating with the right person within our organisation. The only real glitches with the referral process are kind of the ones I spoke about earlier, where it's just making sure that we have that information. I guess from the perspective of whoever it may be that's having that initial contact with the person, it might make things even harder because then you haven't got that local knowledge maybe, which I've never really thought of until you mentioned that actually, but that could prove problematic. But on the whole, I don't think there've been any particular differences regardless of the areas they come from. Can I just add as well, just I'm butting in a little bit, but just to say with regards to training and the probation staff in Lancashire as well, we were all part of quite a large meeting about the rollout and how that would work. And I'm aware that both the ODN and our peers at the Hep C Trust would be involved in going in and offering that training to the probation service there as well. So it would be quite robust, I think, when it happens.
Good stuff. Thanks, Carrie. Another question, probably both to you, Carrie and Colin, really. You spoke in your presentation about asking people before they're released, like what services they'll actually be accessing, and they might be putting one thing on the form, but where can you actually get them? How forthcoming do people tend to be with that information? Like, does it require quite a lot of engagement by the peer before you sort of build up that level of trust? Or
yeah, I can probably come in with this one. It's very, because it's different, isn't it? I think if it works best if our peer is with a nurse, perfect, because the peer will ask them killer questions of like, are you really living there, when he gives the address, you know what I mean? Because we know, you know what I mean? But when there's a nurse on her own and maybe just do a telemed conversation, them questions aren't getting asked enough just because of time. There's loads of other stuff around it, you know what I mean? But I'm fairly confident to know that if my peer's in that room, he's asking about your soup kitchens, he's asking about where you go begging and all the rest of it. And it's like one of the questions that we're going to be doing in one of the breakout rooms is there more stuff we should be asking, you know what I mean? Because we want to ask more better questions, you know what I mean? Like even for probation, we're asking probation, your GP, is there other things we should be asking? Like what library do you go to? Where do you sit? What church do you sit in? You know what I mean? There's all other things we should be asking really to try and find this person.
Yeah. Okay, great. Yeah, so if anyone has any suggestions on that, please do bring them to the breakout rooms. Another question here for you, Mary, from Lee Christensen, also from the Hep C Trust. How confident do you think your staff are in doing Hep C testing, and have any of them actually sort of carried that out themselves?
We haven't got to that point yet. We were really close to it, and we were planning to do the training, etc. I don't expect that it will be too difficult for them because we do the drug testing, and as I understand it, it's very similar. So our staff have already been trained to do swab drug tests. The issue is around safety, and once we've reassured our health and safety reps that it is a safe process, I can't see it being a problem. It's just COVID has really kind of scuppered things for us.
Okay, thank you. That's good to hear. Okay, well, thank you all for answering those questions there. And I'm sure if anyone has any further ones, if you stick them in the chat box or email them over to us, we can pass them on and we'll get them answered after the session. But what we're going to do now is go into some breakout groups to discuss some of the issues that we've heard about this afternoon and get some of your suggestions around this type of work. So there will be a facilitator in each breakout room who will let you know the questions that are up for discussion. So that will be Colin, Carrie, Miriam, and I think Stuart, depending on how many groups we have, but the person who's the facilitator in your room will have facilitator written after their name on the screen, and they will introduce everything when you get in there. So you'll get a message on your screen in a minute inviting you to join a breakout room, so please accept that, and then you'll automatically be moved in. We've got about 20-25 minutes for discussion, and then you'll automatically rejoin the main room at 10 to, and the facilitators will give a bit of brief feedback just on the discussions in each of the rooms. So yeah, see you soon.
So thank you very much, everyone, for your taking part in those discussions. I hope they're really useful and interesting. I'm now going to just go around the sort of three group leaders and sort of ask them to highlight a few key points that were highlighted in their talks. So Colin, you're first on my screen, so do you want to go first and flag some of the most interesting?
Yeah, sure, no problem. First of all, thanks to my group, they were fantastic. Some good answers, good conversations, made my job as facilitator very easy. So yeah, just for question one then, a great suggestion was to have a list of questions for the nurse to ask that a peer would normally ask. So having like not a bit of a script, but just a point of questions for people to be able to ask, which I think is a fantastic idea. Around like areas where you beg, where your using community is, your telephone numbers, your friend's telephone number, your girlfriend's, that sort of stuff. So yeah, lots of really good suggestions around that. Question two, when we started looking at probation, one area was more, who are they, where are they, trying to, establish a bit of a partnership with them. Learn to train the staff first. So in one area, I believe Manchester area, training the staff, getting to know the staff is a big thing. It helps the relationship. And then going to meetings and asking probation to be a partner. So obviously partnership straight away with probation rather than starting something up and then waiting to invite probation. Question three was all around structuring different questions for different clients. So when they're in probation, or we find out that probation have asked the question, did you get asked for a Hep C test when you were in prison? So for instance, if you're a CRC client, you'll be changing your different questions of how you would ask somebody about Hep C. But if somebody's just come out of prison, you should be asking, did you get a test when you were on your sentence? And if the answer was no, I would like that information to be shared with myself if I was the PA lead for that area, because then I want to go into prison and ask them questions, say why didn't this person get tested? And then the last one, COVID was in capital letters for a reason with probation and obviously things that haven't happened yet. And there was different footholds. There was like probation shutting down. There was obviously depending on the sites where you were going, other rooms, COVID friendly, all the things around trying to engage with probation and do a bit of work with them. But then good suggestions were like operational groups and oversight groups. So everybody's involved in one group. And I think we all wrapped it up with something called stability. Just again, probation changing and merging and then unmerging, and we're very same, like services and drug and alcohol services are always changing. Like to do this Hep C work, we need a bit of stability, like with everything we do, because you put one pathway in and then it changes. It's like, if we're going to eliminate something, we need something to be quite solid for a good 5 years, I think. So not too much change. And that was my group. Thank you.
Fab, thanks, Colin. Carrie, you're next up. So do you want to go?
Hi, yeah. So following on from Colin, I think we actually heard from Sandra, who is currently working in Manchester and is doing some great work with probation services actually at the moment, where as a nurse they are going in and running a clinic right now and they're doing oral quick swabs in probation, which is really interesting to hear. We also spoke quite a lot about so in terms of the differences between the two kind of probation client groups that we talked about, I guess, and perhaps that we need to look at reducing stigma, so giving people a whole host of risk factors rather than people just thinking they are being tested because they might have been an injecting drug user at some point, whether they either haven't been or perhaps they don't wish to disclose that. So maybe just something there around the way tests are promoted in probation, being a little bit more focused to other risk factors, not just injecting drug use. We spoke a lot about staff training and education and how important that would be going forward to make, because I mean, Sandra was saying, a couple of other people in the group were talking about it too, and how you know, if the staff don't feel equipped with that knowledge, it's not something that they're used to, even if it's just that somebody else is sitting in the room and always going to be in reception doing a test, that the staff need to have that information too, so that they're able to sell it. And I think that might have been, oh, actually, yeah, we had a conversation as well, in terms of the prison process as well, about perhaps utilising Hep C champions that are in one of the private prisons that was mentioned, and the peers obviously that are in there at the minute. Is that something that they could be having a conversation with anybody tested about, and then perhaps getting that information back to us or back to the nurse if the nurse didn't have time within their session? And I think that was about it for our group, unless I've missed anything. Oh, we did. Oh, one last thing. We just had a bit of a conversation about the fact that within probation services, obviously they do work alongside substance misuse services really closely. But that said, there was kind of an acknowledgement that actually the two might not always completely understand or fully understand how the processes work within each service. So if we're doing some joined up work within those services, it would be really good to make sure that the staff fully appreciate that. So if we're sharing information or are looking at a targeted approach, that can be appreciated. Thank you.
Thanks for all that. And finally, Miriam, I know I was sat in the back of your group, so sort of know a few things that you were talking about, and might have overlapped with what Colin and Carrie said, but if you just want to talk us through sort of anything new and that hasn't been mentioned so far.
Yeah, so again, really good discussion. I think everybody got quite involved with the discussion, lots of good ideas. It was great for me because I was just listening and listening to all the great communication ideas, very similar things. I think the biggest thing that came out for our group was that it was training and making sure that not just nurses in prisons, but all the staff in prisons understand Hep C, understand what happens if somebody is referred through the Follow Me referral form. They're more likely to fill in the form if they understand what the benefits of doing it are, what support does the client get when they actually referred to the community team. But also there was a lot of discussion around staff understanding that, you know, we've moved a long way from the interferon days and treatment is great nowadays, and actually somebody getting Hep C diagnosis is not bad news, it's great news, because we can then support them and get them on treatment. And there was a lot of people in our group felt like nurses and staff in general are maybe still not that comfortable talking about hepatitis C and giving somebody their diagnosis, and that acts as a massive barrier. We also had a lot of discussion about probation services being seen as authority figures and peers being very integral with that, because a lot of times clients will see Hep C PS as somebody that they can actually talk to, and talking to your probation officer can be a massive obstacle. And in general, talking about probation services, there was a lot of discussion about communication being the major obstacle, and how organizing lots of training and joint events can be a good way of getting around that, because the more we see each other and the more we communicate to each other, the easier it is then to work together as well. So that's pretty much it.
Thanks, Miriam. That's great. More peers and more events like this. So that's the great feedback to get. Thank you very much to everyone who has come today. I really hope you find it useful. We will be sending around a feedback form via email. Please do fill that in, because that helps us basically plan events in the future that will be useful to you. This is the last of 5 events we've sort of held in October. And you'll be able to find notes and videos from those events on our website or on our social media on Twitter. So do please pick that up. And yeah, please do fill in the feedback form honestly, because it helps us basically make a better event next time round, and make something like that is useful to you, which is our job. So yeah, thanks everyone, and have a great weekend. Ta-ra.